Hi, my name is Andre Gerges, and I'm a third-year medical student at Michigan State University College of Human Medicine, and I'm presenting a case report on behalf of myself and Dr. Bassnett about acute exertional bilateral anterior compartment syndrome of the legs with rhabdomyolysis. Exertional rhabdomyolysis is a syndrome of skeletal muscle breakdown and necrosis that can lead to serious complications. Although rare and often overlooked, these cases are at an increased risk for acute compartment syndrome. We present a case of a 26-year-old male who presented with lower extremity pain after moderate exercise and was diagnosed with exertional rhabdomyolysis and subsequently developed bilateral anterior acute compartment syndrome of the lower extremities. So our case is about a 26-year-old male with no significant past medical history who presented to the emergency department with pain in the lower extremities that began 24 hours after a 5-mile run. Physical exam was remarkable for bilateral lower extremity tenderness. Labs showed elevated CPK at 1,145, creatinine of 1.55, AST of 52, ALT of 59, moderate blood, and 0 to 2 red blood cells on urinalysis. At that point, a diagnosis of exertional rhabdomyolysis was made. Initially, the patient was medically managed with aggressive IV fluids and responded to hydration as his renal function rapidly normalized. An interval physical examination showed unrelenting tenderness, and repeat labs showed a significant increase in CPK greater than 20,000. At this point, the patient was evaluated for ACS and was found to have ischemic but viable muscles in the anterior compartments bilaterally. Elevated intracompartment pressures, or ICPs, confirmed the diagnosis, and emergent fasciotomies of both extremities were performed. Moving on to our discussion now, exertional ACS is a rare but limb-threatening condition that warrants early assessment and diagnosis, which will significantly impact outcomes. Delayed treatment resulting in ischemia for 1 to 4 hours is associated with reversible neuropraxia, while over 6 hours is associated with irreversible nerve and muscle damage. In a case series of exertional ACS conducted in 2018, 57% of those patients were initially misdiagnosed and received non-urgent treatment. However, diagnoses made under 24 hours had no evidence of long-term sequelae. Conservative treatment may be sufficient in certain cases where there is repeated clinical assessments and a low suspicion of non-traumatic ACS, but a fasciotomy performed at appropriate ICP measurements continues to be the preferred treatment. Our takeaways from this case include exertional ACS presentations can be rare and oftentimes challenging that can develop insidiously. Increased awareness of the presenting symptoms and risk factors along with serial examinations can help address these issues of delayed diagnoses and misdiagnoses. As previously mentioned, early diagnosis and fasciotomy is essential for better prognoses with less risk for long-term complications. And with that, I will conclude my presentation. Thank you very much for your time.